I myself don't know how I end up here. It's definitely a happy accident. So much so, I remember coming away thinking, I'm probably more scared of a root canal than a patient.
Ready for this? Success rates, 88, 89%. And
Wow.
that is documented years and years.
So you've explained what it is, taking the tooth out, putting it back in, but why would you do that?
I thought it was witchcraft at the time. I've obviously come to learn it's not witchcraft.
You pulled down my friend's tooth, fixed it, and put it back in. I figured if you could do that, then you can do a simple root canal on me. So it's a matter of actually educating the dentists in the community to want to save their natural tooth and having this as an alternative. The most important thing is treatment plans be able to get the tooth out in one piece.
So the root canal has failed in that lower left second molar. And we at Protrusive, and you guys who listen, you believe that we should try and save the tooth, the whole tooth, nothing but the tooth where possible, before considering implants. You want to delay implants. Implants are awesome, but they're a replacement for a gap, not a replacement for a tooth. But that failed root canal, what are you going to do? It's already had a fantastic root canal filling from an endodontist under rubber dam. And so the next thing would be apicectomy or microsurgical endodontic. Raise a flap, clean out the abscess, do a retrograde filling. We've discussed that on the episode before. But how are you going to do that for a second molar? There are so many vital structures and nerves that you could damage, let alone getting the access to that region. This is where this little known last resort endodontic technique has a success rate of up to 89%. And I'm joined by the world authority on this topic, Dr. Samuel Kratchman. Thank you so much to Dr. Shiv Mehrotra, who brought on his teaching faculty onto the show as well. I was sat next to Shiv in a crown lengthening course, and next thing you know, 6 years later, I hear from him and he's in the States and he's doing an endo program. And I had no idea about this thing called intentional replantation. And I've asked a few dentists if they've heard of it, and very few people have heard of this strange technique, which actually, with the right case selection, has got pretty damn good evidence base. Look, I'm not going to do it any justice, but essentially that second molar, you atraumatically extract it, you do the apicectomy and the retrograde filling outside the mouth, extraorally, and then you push the tooth back into place. That, my friends, is an intentional replantation. Isn't that just mind-blowing? It kind of makes sense. It makes so much sense, but it leaves so many questions, which are going to be answered by this episode. There are some, of course, nuances and case selection dilemmas and atraumatic extraction considerations, but we're going to do a deep dive into how potentially you could offer this for your patients, because Dr. Samuel Kratchman believes that this is not the remit of the endodontist. You, my friend, could do this. And as with every piece of education, the role is not to teach you every single step, because you'll only remember so much. Yes, there's Ask Jazz, the AI, and everything will be recorded and there's a reference. But if you do identify a case that based on this podcast that you want to do read the literature, do read the protocol step by step that they follow in the literature, do read that 1997 paper by Dr. Samuel Kratchman, which we will put in the show notes. But please enjoy this episode. It is an absolute cracker. The protrusive dental pearl I give you is very much in relation to the key themes of this episode in intentional replantation. If you ever do this treatment, let's imagine that second molar, that lower left second molar I described. Be careful with how you extract the tooth. Be very atraumatic. Try not to use forceps on the root. Why? Because the root has the PDL, and the PDL, that ligament, is make or break. And just like we do with an avulsion, right? When an avulsion comes through, we want to keep the extra oral dry time as low as possible. So if you do atraumatically extract that second molar, then be efficient. You want to do the retrograde filling and everything involved as efficiently as possible. You want to, of course, store it in saline, and all these things are there to protect the PDL, because when intentional replantation fails, it fails biologically before it fails endodontically. Think of resorption and ankylosis and that kind of stuff. Once you do the hard bit, which is the atraumatic extraction, the retrograde filling is actually easy, and that's going to fill you with confidence in the rest of this episode. Just remember to protect that PDL. Let's now join Shiv and Dr. Kratchman. Catch you in the outro. Shiv Mehrotra and Dr. Samuel Kratchman, welcome to the Protrusive podcast. So nice to have you from across the pond. Let's start with you, Shiv. Shiv, we met. I know your cousin. I went to school with your cousin, and then I sat next to you on a perio crown lengthening course.
Yeah.
And years later, I hear from you that you're in America. I was like, wow, okay, this is cool. So tell us about yourself and how you ended up there.
Yeah, hello. Thanks for having me, Jazz. I myself don't know how I end up here. To be honest. It's definitely a happy accident. But essentially, just to rewind, I finished dental school at Leeds. I came away thinking I never want to do an exam again. And then during VT, I realized I didn't quite know what I was doing. And in particular, I didn't really know what I was doing with root canals. And it was something that scared me so much so. I remember coming away thinking I'm probably more scared of a root canal than a patient, which is a weird thing, really. With that in mind, I took on a few TCT roles, and essentially I just went to the faculty and told them, look, this is something I struggle with. Please help me. In Cardiff, there was some lovely faculty there. He took me under their wing and just demystified it, unraveled it for me, and just helped me sort of learn in a controlled environment. And then just piece by piece, I guess, just one of those things, you just learn to kind of love the progression and you get addicted to that growth. And then I just went from being someone quite nervous to someone who just enjoyed, appreciated it, and then decided just to pursue it indefinitely. In terms of how I ended up here at Penn, that was something of a perfect storm. So I knew I wanted to do endo. At the same time, a lot of my sisters got married and they moved abroad here. So my head turned about what life might be like abroad. And then looking at different programs, I came across Penn and, all the great surgery things and the opportunity to spend time with Dr. Kratchman himself, who you'll hear on today. Essentially, I just shot my shot. I managed to somehow get in and I thought it's a once in a lifetime opportunity. So I just took it, really.
I recently hosted the two ladies, Hazel and Doreen.
Yeah.
Did you catch that? Did you see them around?
Yes, I do. So I knew them quite well. They're actually teaching here, so I bumped into them quite often. And last year they were residents alongside me as well. So yeah, I do. I saw the episode.
I feel like everyone I know is at Penn right now and doing great things. And Dr. Samuel Kratchman, thanks so much for joining us to give us your experience and all the wisdom that you have. Tell us about yourself, how long you've been affiliated with Penn. Tell us about your career journey. It's nice to learn about what got you to where you are.
Thanks. First of all, thanks very much, Jazz, for having me here. It's a pleasure and honor. First of all, for Shivs, we needed a resident with a British accent. Like we didn't have, we need to diversify ourselves with training. We quizzed him on American football before we would allow him to see if he could get us Liverpool tickets, which is very difficult coming from America. So myself, I'm born and raised in New York and then spent 8 years in Boston at Tufts University for both my bachelor's and dental degree. Then I came to Penn for 2 years. I had only black curly hair and a beard similar to Shiv's, not all the way. Endo was funny. It was kind of by default where at Tufts, we had to do a lot of prosthetic work, including all our own lab work, meaning waxing up teeth, testing crowns, even flasking dentures. And the prosthetic professors were only a couple of years older than me, and they would go out drinking with you on weekends, but then during the week, they would look at my wax up and say, this looks like a toe, and throw it on the ground and step on it after I spend all weekend waxing it up. The endodontic professors at Tufts would put their feet up on the table and say, Sam, how can I help you here? So I got a good feeling about endo. And in all seriousness, I feel that being a general practitioner is perhaps the most difficult type of practice because you have to be an expert in everything. And that's not how my mind works. I'd rather focus on one particular field. Economically speaking, endodontics is great because regardless, and we say it's recession proof because if patients are in pain, then they're going to motivate to go and come to you. And as an endodontist, it's very rewarding that, in a matter of minutes, we could at least open up a tooth and relieve the patient of pain. So in that respect, that kind of what driven me. I was always like a New Yorker at heart and figured I'd finish Penn and go right to New York. And thankfully, my wife, who was my high school sweetheart, said, we're not going back to New York. It's too much traffic. It's too expensive. And I took a job in Philadelphia. And similar to like a mushroom, like a fungus that grows on you, Philadelphia, it kind of grew on us. And it's been our home since 1989 and raised our two children here, and it's really been a nice journey. And in terms of teaching, when I finished the program, I came back and started teaching 2 days a week the following week, because I knew if I started to work 5 days a week and earn a real living, I would never give up part of that to teach. So I've always had 3 days of practice, 2 days of teaching for 35 years now, and have 4 private practices in the suburbs of Philadelphia and 7 doctors, all of which I trained at Penn, and it's my family, as is Penn, and my residents are my family. And then I've always been 2-day faculty. And honestly, the residents like Shiv would keep me going and keep me young. And it's the more enjoyable part, let's say, of my week. But then the practice part obviously pays the bills and also keeps, my hands, dirty and able to work.
What a lovely balance you have in the week, and that's great to hear. And honestly, very excited to just distill your experience that you have. So we're talking about intentional reimplantation. Would it be replantation or reimplantation?
It's funny that you say that, because technically it's replantation, because you're only taking it out once and putting it. And I've also been criticized for some reason in history. It's been known as an intentional replantation, as if, of course, it's, every time that I'm doing it intentionally. It's not something that, I accidentally. One year, a resident of mine tapped off a bridge and took a tooth out with it. And then he said, "What should I do, Dr. I said, "You're going to unintentionally replant that, because you didn't mean to take it out." But really, it's just, in the textbooks, it says intentional replantation, but it is replantation. The important thing is not to confuse it with the term transplantation. Now, transplantation, for example, taking a third molar and transplanting it to a first molar site, these are done, and I have done some, not nearly as much as replantation, but that's much more difficult and lower success rate. The beauty of an intentional replantation, and this is how I describe it to patients, is that you're taking out the tooth and you're putting it back into its original socket. So it's not, you don't have to worry about rejection. And then not a joke, but I'll say to them, "Hey, look, in medicine, they've been transplanting heart from, an animal to a human, or from a human to human. And what you worry about most is rejection, which with replantation, you don't have to worry about rejection, because it's your own tooth going into its own socket." And it's been around for many, many years. And the articles that we read and that the residents read go back to the 1960s. And it's a procedure that I want to talk about today to show that everybody, after they listen to this podcast, should think about this in their own minds, that they could do this in their own practice. It's not magic that, you have to be an oral surgeon with 30 years of experience. You could be a dental student who's taking an oral surgery course and learning how to take out a tooth atraumatically, which is the most difficult part. And after that, everything is done outside the mouth. It is a relaxing and easy procedure. Ready for this? Success rates, 88, 89%. And that is documented years and years. There was a paper out in 2017 by Dr. Minkar, with a systematic review from the 60s all the way to 2017, and success rate of 89% of replantation.
I mean, the first question, good confirmation there, Shiv. But the first thing to check is, for those who haven't heard of this technique, even though it's been around for so long, it's something that it's not really, it's not even touched on in dental school. I probably may have read it once upon a time, but I've never done it. I don't even know. I go to a lot of CE. I haven't seen anyone present, not even once, this. So you've explained what it is, taking the tooth out, putting it back in, but why would you do that?
Sorry, just to add on to what Dr. Kratchman said, because one of my motivations for wanting to do this talk, just based on what you said, in our education, it's not really mentioned. I had no clue it even existed. In fact, the first time I saw it was when I came here on a visit, and I thought it was witchcraft at the time. I've obviously come to learn it's not witchcraft. It's based on hard science, evidence-based, etc.
Because
So,
Shiv, like you trained in the UK like me, so we were
yeah,
taught in the ortho clinics, like multidisciplinary, they talked about auto transplantation. They talked about that.
yes,
You know, a wisdom tooth being used to replace a central or a premolar for a central incisor, that kind of stuff. But I
yeah,
hadn't heard of replantation actually.
yeah. Which is bizarre, and I think I've come across like lectures and things where you know, it's been presented at like an international conference or what have you, and in the break room, everyone's sort of talking about it and sort of baffled at how it, you know what it is and whether they can really do it. Just to add testament to what Dr. Kratchman said as well. So a lot of something that's different to England. So I just want to highlight this. A lot of dental students will go straight from dental school into residency, which is a big difference to England, where you kind of have to rack up your years in DCT and practice and so on. So essentially, we have residents here where they've only done the requirements of an undergrad, and they're going straight in and able to do it confidently with precision, essentially. So yeah, it just, with that in mind, I just wanted to highlight how user-friendly it really is and applicable it is.
Well, what are the indications? What are the ideal scenarios? And before we hit record, you mentioned certain teeth, but like, what would be the requirements or the indications for this treatment?
Sure. So first of all, I'm the director of their surgical part of their program, meaning a tooth that's already been treated and is failing. We're always going to think about retreating it conventionally first, endodontically. So now you look at reasons for possible failure and you look at location of the tooth. So you always have to consider being conservative at first. But when you have lower second molars that are too far back to reach, the bone is too thick. When you have upper molars that are close to the greater palatine bundle, that are completely in the sinuses that are difficult to reach, that's the two most common teeth that we're doing. And that's totally indication for doing a replantation, because you've already done the root canal, you've done a retreatment, and now there's a persistent infection. And you want to say to the patient, well, first of all, you have to be realistic. The most difficult part is the treatment planning, meaning the tooth has to be conducive to being able to remove it in one piece. And obviously, the more of these that we do, it's easier to look at a radiograph and say, well, these roots are pretty straight. And even the best case is when there's some bone in between the roots. That makes for not only a nice extraction, but when I replant it, ready for this statistic, less than 15% of the time do I even splint it. Because if you take it out carefully, and I'll talk step by step as we go along, then the concept is to take out the tooth by gently luxating it. It's not causing like acute inflammation and widening of the socket. Not how fast can I get it out, it's how atraumatically I can get it out. When you take it out, there's the lesion is attached to the root. You cut off the end of the root. We use the microscope for documentation purposes, but pair of loops is fine to see. You prepare the end of the root, you fill it, and then we put it back in. We manually compress those plates because by gentle luxation, we're opening it up, and then we manually compress. We would have the patient bite down on gauze. We go over post-op instructions, x-ray, and then we check mobility. 9 out of 10 times, it's +1 or less. So you don't even have to splint it. Patient walks out with their tooth and not even with splinting. If in fact, if you splint it and you leave the splint on too long, it's going to promote ankylosis and actually could be detrimental. So the main cause to think about, number one, is, as I said, lower second molars due to the proximity to the bundle, how thick the bone is. Upper molars, as I said before we were recording, if anything, upper molars are even easier to remove in one piece because the maxilla is thinner and more pliable, more elastic to be able to get it out. I did tell you about some cases that we did that we published of lower bicuspids where there are lateral canals, they're lateral lesion, not due to a fracture. And in order to get to that lesion, you would destroy bone and probably destroy the tooth. We've done replantations with cases like that. Those are even easier because the roots are conical. So in extracting it, you could even rotate to take it out. So that's another please stop me if I'm talking too much.
No.
So you have a post sticking out, perforating the tooth, and you can't get to the perforation surgically. Let's say it's going towards the furcation lower down, or a palatal root of an upper bicuspid. There's a post perforation, and to go in surgically, you'd have to cut through healthy bone, healthy root, and now sacrifice crown root ratio, pull out that bicuspid, leave this root alone, address the perforation, and put the tooth back in. There's so many different reasons to do it. I've done several hundred of them over the years, not all myself, but with my residents and my partners. And it's just what you said before is true, in that a lot of people don't know about it. Even in the United States, it's pretty rare in our program that we teach this and we do it. And I know this because in all my years of practice, when I send a report back with the replantation, I always get a call from the dentist. What did you do there? You know, you pulled out the patient said you pulled out their tooth, like, you crazy. And it's an amazing practice builder. I've had patients referred to me that I never heard of the dentist. I said, where'd you get my name? And she said, you pulled out my friend's tooth, fixed it, and put it back in. I figured if you could do that, then you can do a simple root canal on me. So it's a matter of actually educating the dentists in the community to, want to save their natural tooth and having this as an alternative.
I mean, in a nutshell, if I was to just simplify, it's the easiest apical surgery you'll ever do. If you can get the tooth out atraumatically, is basically how can we make this apical surgery not anatomically compromised or difficult in that manner. So I think for our younger audience, we just need to clarify some scenarios whereby you may actually decide that actually that's a step too far. You need to do the retreatment, the root canal retreatment first, which is, like you said, you already mentioned, trying to be conservative first. Because if you have a poor quality obturation, unfilled canals, instrument fractures, signs that and you know that perhaps it was not disinfected well, then the first port of call would be the root canal retreatment. So how can you help our younger listeners to look at their radiographs and look at the tooth that they have in the mouth that they have for, let's say, a lower second molar, and what are the factors that should be tipping them towards, okay, definitely do the retreatment first, like root canal retreatment, rather than jump for anything a bit more surgical in that manner?
Perfect question. Yeah, great question. Broadly speaking, you want to look at the tooth and essentially understand what your skills and limitations are based on what the challenge ahead of you is. So essentially, if you can look at the root canal before you and you think that you can do a better job than what you see, then essentially conventional makes the most sense. So, let's say there's not a big crown and a post that you have to get away through. The GP doesn't look that hard, and maybe there's a separate instrument, but you think you've got it in you to get it out, then of course conventional retreatment is on the table. But occasionally you're going to look at these cases and think, there's a curve there, the instrument's past the curve, I don't think I can access it. There's lesions associated to that tooth as well. Plus, anatomically, it's in a place where surgery isn't the most approachable or easy in your particular skill set. Well, then that's when you're going to sort of think about intentional replantation. And essentially, that's where it fits in that treatment hospital.
And that's great. And you also always have to be honest with the patient. And I'll tell you what the very best patient is. Patient comes to my office like, I had a root canal. I had a second root canal. It's like enough already. Like I'm ready to lose it. And every patient for every replantation has to be mentally prepared to leave the office with one less tooth. They have to be mentally prepared that they're going to lose the tooth. And these are the words that I say. I say, okay, you have two choices here. You can go to the oral surgeon. They'll take the tooth out in about 5 minutes and throw it in garbage. Or you can let me try to take the tooth out. And if I can get the tooth out without breaking it, how do you feel about me fixing it and putting it back in? And I'll joke. I'll say, you're 50 years old and this is your 12-year-old molar. You've had it for a long time. Why not, try? And when you explain it to them that way, and don't get me wrong, if it's fractured or cracks, then I'm not charging them for, a surgical procedure with the replantation. And those patients are the best because it's a win-win situation. If it's fractured or if you can't get it out, then they expect it. And the interesting thing is that you would think with how popular implants have become, at least in the US, I'm not sure about UK, you'd say, oh, this is probably something you did 20 years ago. You don't do so much anymore. It's the opposite. 20 years ago, when implants were going crazy and everything was getting extracted, and endodontically teeth, the implants were getting extracted because we know an endo is eventually going to fail. Now, in the United States, the pendulum is totally turning to saving your natural teeth. And this is a great alternative because worst case scenario, yes, the replantation fails or fractures, then the patient gets an implant. But we now know the implants are not 100% successful. And what happens if an implant fails? That's much, much more difficult to manage. So it's really just a mindset, and it's something that we should all just keep in the back of our minds as a possibility for treatment.
Well, in those teeth that you described as being the most common teeth, they are also the most difficult for implants as well because of sinus, because of the fact that it's a lower second molar. So sometimes that replantation may be the last chance saloon anyway in a lot of these cases. Which makes a lot of sense. And what you said reminds me of a recent episode we did on surgical extrusion of, let's say, anterior teeth and premolars, where they take it out atraumatically. They don't often take it out all the way, but they just enough so that they can splint it again, and now they have the ferrule. In your case, you're taking it out, you're chopping off the ends of the root, you're doing your cleaning and your, I guess, a retrograde restoration?
Yeah.
Yep, you're putting it back in, and I guess it's a bit like when you have an avulsion in trauma. The extra oral dry time is in a very controlled situation. You try and create
So that's the important part. But then I want Shiv to talk about his case this afternoon, which falls right into that. One thing that's very, very important. Two points, and then I'll let Shiv talk. The most important thing is treatment plans built to get the tooth out in one piece. Okay. Now, once the tooth is out of the mouth, we did a study 10 years ago. You have to keep that periodontal ligament moist. So there is no extra oral dry time. So we've done all our studies, and Hank's balance solution, which is a transport media, basically mimics the constituents of saliva, and it keeps the periodontal ligament alive for 30 minutes. Okay. Now you can buy that from a chemical, or you could go to the supermarket and buy what's called Pedialyte, which is something. Do you have any?
Yeah, I've got to interject it. Unfortunately, we don't have Pedialyte itself. There are alternatives like Diarylite, which is a sachet, and you have to mix it with sterilized water. But Pedialyte, you're going to have to find an import. If you message me, I'll try to bring some back over Christmas. We have alternatives. Diarylite is probably the brand that you're looking for, unless you can find something on Amazon.
Yeah, but that's the key, because when the tooth is out of the mouth, you have to keep those cells alive. So when you go to put it back in, the body doesn't reject the tooth. Side point, I'm getting a little technical, but when you gently luxate, expanding the plates of bone and take the tooth out successfully, you're severing the periodontal ligament. So this periodontal ligament on the root, that stays live via Hank's Balance, a Pedialyte, or some type of ale, that is there. And there's still viable PDL in the socket, lining the socket. So I found that the hard way years ago, where I would go and scrape in there thinking maybe there's some granulation tissue, but no, you don't want to touch the walls of the socket because there's important periodontal ligament there. So when I replant the tooth and I compress it, I want those cells in that socket to join with the PDL on the root for reattachment. Very, very important. Now, Shiv, just today, wait to hear about this case, and he was thinking outside the box of a way to save a tooth.
Yes. So essentially, I don't want to confuse people, but essentially, with something like replantation, it's a very simple procedure in terms of your decision making as well. You're thinking about conventional surgery and then reimplantation in terms of your timeline. Very occasionally, you will have to think outside the box. In this particular scenario, a young lady, she had an upper molar tooth. We did the retreatment. It wasn't successful, unfortunately. And the root that was affected was the palatal. For those of you who do surgery or familiar, palatal approaches aren't the most comfortable for the clinician or the patient. So it's not advised. In this particular one, the anatomy was too close. So it was just contraindicated. Thankfully, not thankfully, but I guess she's also undergoing orthodontics at the moment. So one of the discussions me and Dr. Kratchman had was potentially even though this tooth had quite splayed roots, which traditionally would not be the most fun extraction, because she's having orthodontics, can we orthodontically extrude that tooth a little bit for us? So just ask the orthodontist just to tighten those brackets a little bit, give us a little bit of mobility on that tooth, a little bit of extension. Yeah. And then whilst they're doing it, we can always file down the crown a little bit because it's a stainless steel, a whole crown essentially on top of that tooth for the moment. With that in mind, we could potentially take the tooth out in an atraumatic way, assess it, snip off the root, as you mentioned, retrofit it, and then put it back as though nothing even happened. Of course, we'll wait and see how that turns out. But these are things that you can sort of delve into and diversify which will come for sure.
I mean, I've got so many questions, but I think the best way to tackle this next bit is if you go through like in a standard case, the protocol. I mean, the first question I have is imaging. What is the minimal level of imaging required? Do you need a CBCT to exclude a crack, or is a crack something that you'll always, when you inspect the root itself, you check for? Let's start with imaging, and then maybe step by step from there, including, one of the questions I have is, yes, you described the solution that you put it in, but how does that actually work? How do you actually keep the tooth still? Or I'm just trying to think of the ergonomics and the actual mechanics behind actually how you actually do it. Hello, YouTube Protruserati. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on Protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I wanted to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at it, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
Yeah, but of course. First time imaging, like you said, here at Penn, we'll always take a cone beam CT for this particular case. The reason for that is you kind of want to know the anatomy of the tooth that you're dealing with. You want to see, will this tooth come out in a feasible way? What's the best approach for it, the best angle, etc. And of course, its relationship to different anatomies. Once you're happy with that, in terms of actually doing the procedure, and you talked about the sort of the solution, the Hanks balance or the Pedialyte, it's very simple. You're going to have your assistant, they're going to have a syringe of it ready. And as soon as the tooth comes out, you're going to have a little bit of gauze there soaked in it. You're going to rest it over the tooth. Make sure you're on a surface so you don't drop the tooth. Very important. And then little by little, they're just going to gently, I suppose, squirt a little bit, drop by drop on it, keep the tooth moist whilst you're working on the tooth, inspecting it, dyeing it, whatever you need to do. And then once you're ready, you just pop it back in the socket.
So you asked a very great question. Let me just elaborate a little bit. Well, two things. First of all, with the CBCT, unfortunately, you often cannot see cracks or fractures because you're getting too much distortion or noise from the posts, from the crowns, or even adjacent teeth. But you're looking at the pattern of bone loss, I should say, suggestive of possibly a fracture. But for sure, either if you take it out in one piece or if it breaks while you're taking out, you confirm. Most frustrating is if I get the tooth out in one piece, I'm all excited, and then I see the root is cracked. Forget it. Like I've tried cutting into the crack and putting like a bioceramic there and putting it back, but that doesn't work. But the funny thing that you mentioned is that how do you stabilize the tooth? And we have special forceps. We have 2 forceps that we use for all that has a good grip on the tooth. Okay. Then we put the rubber band around the handle of the forceps so that once we take the tooth out, if your hands listen, you hold on to it. But what's funny is that we work under a microscope, and I make sure that the resident positions their hand like this when they're looking, because, like with Shiv, if he's done like, I'm holding his hand so he's not going like this while we're trying to look through the thing. Because you're right, when you're working on a regular patient, the tooth is in your mouth, right? As opposed to holding it. So you really just have to keep the arms rested down, and we're looking through a scope or loops. But it's just so easy because you're just cutting the end of the root with a high speed. We're keeping the tooth constantly bathed in the solution to keep the cells alive. But we have a little emesis basin, it's called, a little basin that we fill with the solution. So we could always pause and dip it and keep it moist, then work and then dip it again. And then one of the most difficult parts with lower molar apicals is angling your ultrasonics when you do the root end preparation. But here you're looking right at it. So that's even easier. And we do it with the high speed. And then we always place a root end filling with a bioceramic putty, also that we've researched at Penn for close to a decade. And that's a great compatible material that we use for all apicals and for this. And then we, replant the tooth.
In the bone grafting, I don't do implants, but I've been on a grafting course before, whereby they put some doxycycline, like they do some curettage of the infection, of the chronic infection area. They try to remove all the granulation tissue. They put some doxycycline for some minutes and they rinse it out. Is there anything sophisticated like that required in what's been described in the literature? You made a really good point about not being overzealous to get rid of that PDL, which is more coronal. But if there is usually an apical infection, I imagine we're still curating that area.
Well, first of all, the apical infection usually comes out attached to the tooth, and you're cutting off the end of the root. If there's some tissue down apically, yes, we'll suction or we'll, remove it with forceps. I just don't want you scraping the walls of the socket. So you bring up very good questions. In terms of treating the socket, every single time I give this lecture, I'm asked that question, especially when I'm overseas. And now I actually answer the question before it's asked because I know it's going to be asked, especially overseas. There's a lot of endogain, there's lots of different things to treat sites, either osteotomies or in this case, the socket. There's really no indication for treatment of that socket. We've been doing PRF studies here at Penn now. I'll say, well, maybe we should put some, protein-rich fibrin or something down in that socket. There's really no indication. I'll explain why. It's very interesting. And this is, there are a lot of studies out in our field with this. Where is the bacteria when you do a root canal? It's in the canal space, and especially apically in that apical delta. When you have a lesion or granulation tissue around the tooth, there's an extra radiculum, meaning there is biofilm on the surface of the root, but all the granulation tissue is inflammatory tissue. it's sterile. So once you cut off the tip of the root and get rid of that, along with whatever tissue is left, if there's little pieces of tissue left, that's inflammatory tissue. Any inflammatory tissue actually has some growth factors. It can attract osteoblasts. So I would much rather you leave a tiny bit of tissue in there than going and scraping. So you're really taking care of the source of the problem, which is the tip of that root, and prepping it and sealing it to make sure that there's no leakage coming out. And every single resident always is so like nervous about, am I leaving one piece of tissue here or one piece of tissue there? I just say it's not going to have a negative effect on treatment.
Gents, I'm going to throw a curveball scenario your way now, right? Something that really is at the crux of endo-restorative. Let's say you have...
we don't say cricket.
Oh, a cricket curveball. Oh, that's very different than a baseball.
A dusra. I'm gonna bowl a dusra at you. Okay, so the scenario is we have the lower left second molar. It's root filled and it looks well condensed. The root filling looks okay, and therefore you're thinking, because of anatomical reasons that you mentioned, that apical surgery is going to be very difficult there. It may be a candidate, and the roots are not too funky and curvy that you think you'll be able to retrieve it. However, there is secondary caries under the crown, right? And so you need to go back to basics, I imagine, remove the crown, fix the caries, put a temporary crown on, and then do the replantation, right? It sounds too basic, but that's a fundamental principle.
I would say that's mandatory. You want a good coronal seal before you start doing anything, because essentially there's no point doing a retrofill or getting a great apical seal if that coronal seal is flawed, because all you're doing is inviting more bacteria to cause a nuisance. So yeah, to answer your question, yeah, spot on. I would do it exactly in that workflow.
One more thing.
But the curveball there, the tricky element of this is, fair enough, our restorative dentistry, our ability to achieve a seal may be predictable.
Yeah.
But when you come to let's say you do that, you put a nice temporary crown on, and then you start taking the tooth out, and all your core, everything fractures, it now goes subgingival, you've lost your ferrule, you know, despite your best efforts, because these are heavily restored teeth often, or you take it out and the root cracks, and therefore you essentially wasted the patient's time and resources. So that consent discussion, it gets a little bit more complicated in these scenarios where you have to do a lot of the restorative foundational work before doing something that's a bit of a maybe afterwards. Do you get what I'm trying to say?
No, absolutely. You're quite right. And I guess in terms of that's where the discussion with the patient probably becomes paramount. I think, I know you've done an episode with Dre from Dre Composites, and he always talks about the CYA statements. They cover your, statements. And I think that is prudent. Essentially, when you're having these conversations with the patient, it's paramount that you say that, look, this tooth traditionally is, quote unquote, unrestorable or slightly not in the best nick because it's pretty battered for whatever reason. It doesn't have a great prognosis. Most likely it may be due for extraction. All we're saying is if there's the opportunity for us to take this tooth out in one piece and do what we need to do to, make it whole again, essentially, would you like us to put it back in and essentially see how many more years you can get out of it, essentially? And then it's up to the patient whether they, roll the dice or they prefer something a bit more, terminal with just an extraction and no replacement. But essentially, at that point, the patient kind of has to take that risk as well to some degree.
And also to expand on what you said, almost all the teeth are fragile in a sense that they've had a root canal, they've had a second root canal, they have a crown buildup. Absolutely correct. So first of all, if there is recurrent caries and they get a temporary crown, that's still, at least in the US, can be worked out with their general dentist. Like, say, do me a favor, can you take off that crown, reprep it, remove the caries, put a temp on, not charging the patient yet for full crowns. You haven't delivered it yet, and then let me do my replantation to make sure that you have enough tooth structure first. Now, whenever there's a crown on it, which is much greater than 50% of the cases I've done, I always keep temporary cement on the table. And years ago, if the crown came off, but the tooth was not broken, and I did the replantation, I would put it back in the mouth without the crown and say, wow, this is great. Now there won't be any occlusion. Patient will feel great. But the problem is, I learned the hard way, you got to get that crown back on pretty soon, or else the tooth is going to super erupt or won't fit. So now, if the crown comes off without damage to the tooth, without breaking, without taking out the whole buildup, then I do my replantation. and my assistant is cleaning out the inside of the crown. And the last thing that I do outside the mouth is re-cement the crown with temporary cement and wipe up any excess and put it back in so that I don't have to worry later on doing it. If the crown and buildup come out, well, then I'm looking under the scope. Is there a crack? Is it damaged? And if not, you better keep something handy there that you can put inside that access if you want to take it out of the existing crown or put it back as a whole. And I mean, another question, I'll probably jump ahead a little bit, is that let's say the crown breaks, but the tooth is still successful replantation. When can the patient get a new crown? And we usually like that they give it at least 3 to 6 months to make sure that this is successful, meaning there's no resorption, no ankylosis, it's comfortable, it's functional, and then you can prep it and get a new crown, and then there's less risk involved with it.
With this technique, it's essentially inducing as atraumatically as possible, but it's still a sense of trauma for the PDL. And then obviously you mentioned the resorption risk. Do you have any numbers on what percentage may have such a complication? Is that encompassed within the 89% success rate? The 11% that fail, is it because of resorption, or is it because of a lack of tooth structure, or is it because of reinfection?
So, let me answer. Okay. It's a perfect question. And whenever I give this talk, I always have to be upfront. The 89% success is on cases that the tooth was successfully removed. And I'm always asked the question, how many times have you treatment planned a replantation and it becomes an extraction? And it's a perfect question, but I can't answer it honestly because, for example, in private practice, I'm much more careful the cases I choose. Maybe there's a little mobility to begin with. Maybe the roots are fused. Pretty confident I can get it out. Whereas at school, in a learning institution, maybe we take a little bit more risks, right? And
push the boundaries.
Yeah. And we also don't know if the tooth cracks. Did I crack it trying to take it out, or was it an existing crack? So we had our resident Muhammad who tried to go back and look at all the treatment planning at Penn to see, how many times was the code for replantation put in, and then it ends up as an extraction code afterwards. And it's a very difficult question because you just don't know whether it's a cause and effect, when the U-cause crack, whether it existed already. But the success rate of 88, 89%, which is very well documented, is on cases that have been successfully removed and replanted. And as you said, you hit the two biggies. That 11, 12% failure rate is going to be from either resorption or fractures or cracks within the first year. So most commonly, if it will fail, it's going to happen within the first year, and it's going to either be from aggressive resorption, like when you're luxating a tooth. Obviously, you're going to get a little damage here, a little damage here, and if you get a little bit of resorption, that can actually tighten the tooth, keep it okay. It's not going to fail. It's those cases where it just the body rejects it, and within the first year, the tooth just looks like that, like a moth eating it. And the other thing, sorry, I'll let you out. The other thing for failure it's usually going to be within that first year, is if a tooth maybe had a crack that we didn't see, or with use of it after implantation, it develops a crack. If you get past 1 and 2 years, then it stays like this. It's not gonna drop down that much.
Yeah. So just to add to what Dr. Kratchman said, that sort of replacement resorption, that severe unrestorable resorption, while possible, that is quite rare. It's not common for that to happen. I mean, there's a really good study. I think it's Cho 2016 even, and they talk about how many times have they tried to take the tooth out and it's failed or whatever. I think out of 150 odd teeth, only 5 times they broke the tooth in some kind of manner that it wasn't salvageable. So I would say that's pretty good odds. In terms of when the tooth's put back in, what can go wrong, the most common complication the literature describes is probably ankylosis, which is still roughly 16%. But ankylosis isn't really a bad thing because it's transient, it's not complete, and it's not replacement resorption where the tooth is being eaten up itself. It's just fusion of the tooth with the bone itself, which is essentially a natural implant. So, when you take that out the equation and look at the true complications, it's very low, sub 10%, you could call it.
I guess then if the success rate is 89%, the survival rate should be quite impressive.
Yes. I think there's again, data where they try and statistically map it. It can be 93, 94% easily.
Mm-hmm.
I think there's a 12-year study. It's probably the best quote you could get.
My final question, because I think this has been very inspiring. It unlocked an area of everyone's brain that, yeah, this makes sense. And why weren't we talked about this before? And I think this would be for a lot of colleagues, okay, that's interesting. And it's one of those where in private practice, it's sometimes you have to wait for the right case to come along. When it does, you have an opportunity to really implement the knowledge that you shared today. I don't think you have described it in a very tangible way. I don't think it's rocket science. I think it is within the remit of a skilled general practitioner. I think you give me confidence. I think the initial mistake that a young colleague could make is trying to suss out, can they remove this tooth or not as atraumatically as possible. So it's really the hand surgical skills and being good at atraumatic extraction, which, like you said, the most difficult part. Once you get it out, actual retrograde restoration with a putty, that's all fairly simple and it makes sense. What are the types of radiographic signs, I think we should finish on, that tell you that, whilst it would have been a great idea, this tooth is not going to come out atraumatically and therefore this replantation is not on the cards?
Shiv spoke about it a lot, so I'll back into that in that the best choice for replantation are roots that are fairly straight with, believe it or not, some bone in between. That's the best candidate. Those will come out without breaking, and those will go back without splinting. When I show a picture of a fused root, and one thing that we see an enormous amount of times on these second molars that fail, even though the radiograph looks like it's a well-done root canal, is you have the phenomenon called a C-shaped canal, where you have the letter C, where you have 2 or 3 main canals.
I get nightmares about this. I used to work in Singapore. I know about the... So I get nightmares about these C-shaped canals.
Yeah, exactly. The Asian population. Very, very true. And even though in the United States we have all these different lasers and negative pressure and general wave and all that kind of stuff, it's almost impossible to clean those isthmuses or fins. And that's all the time when I take out a tooth, I see this letter C. And you know what I do? I take a small 245, a 330 high-speed burr, a little flanger burr. I sink in 3 millimeters and I connect the dots. It maybe takes 30 seconds, right, to just connect those dots.
And this is all retrograde, right? This is still retrograde.
Yeah, all retrograde, all retrograde, and put our bioceramic putty in there. So we're sealing that. So those cases are more ideal for removing, but those cases, when you do replant them because they're fused, will be more mobile. And easy ways to splint it, either take a suture or two and go over the occlusal surface to just passively hold it down. Or, these fiberglass splints, the rib-on, or we have glass bend, which is either a rope or a flat fiberglass that you could use to splint it. That inside. When the roots are dilacerated or curved, that's the number one reason you're not even going to attempt it.
But just to add to that, so I know you asked about sort of tooth-related factors, but also the technique itself. There's something called the O-gram technique, where essentially you are leveraging the tooth's own ability to aid you in the extractions. Something I didn't actually know, and again, I only came to learn through my teachings here, really, was when you obviously do your sort of levering movements on a tooth, you induce a lot of inflammation. Well, inflammation will actually help you by severing the ligament, expanding that site, and giving you more space and mobility to take the tooth out. It will actually degrade the PDL for you. You just have to be patient, give it time. And I think the whole premise of the O-gram technique is to do these very exaggerated movements and hold great pressure and actually give it time. Sometimes just wait, not long, maybe 10 minutes or less, come back to it and you'll notice it will be more mobile for you to have your second go and get, successively more mobile. So 2 factors for sure, but also the technique. Once you understand what's going on and how to do it, becomes much more easier and definitely more utilitarian for even, new dentists in my opinion.
That was perfect. I'm glad you brought that up. So I didn't mention that. I'm always asked the question, how about having an oral surgeon come in to your office for that day and help you take the tooth out? I don't want the oral surgeon there because they only know one thing: hemisect it and take it out as fast as possible. What Shiv said is absolutely perfect. It's a gradual motion where you lean and you purposefully stay there. And then you lean lingually, purposely stay there. And with the overground technique, even talking about a little bit of rotational forces. And then I joke, I say, take the forceps off, have a cappuccino, have a smoke, whatever you call it.
I was just going to say that because that's what I've heard as well. You go for in England, we say go for a cup of tea, come back or come out.
Exactly. Then all of a sudden you've explained that now there's hypermobility. Then do it a little bit more, a little bit. Not this, just do it, exaggerate to that. The CBCT, we have this beautiful case in my presentation of a curved root, but the CBCT showed me because of the curvature, if I luxate this way, I'm actually using the curvature of the root to help take it out. If the root's curved like this and I luxate this way, then it's going to go and it's going to break as I'm trying to get it out. So with that 3D imaging, and for years I did it without even 3D imaging for CBCT, it's actually helped. It's our roadmap to be able to determine, what direction or how can I get this tooth out without breaking it.
Excellent. My final one is a post-operative instructions. I imagine don't eat on that side, analgesics. I don't think there's antibiotics needed, or are there? Is that standard protocol?
That's a doctor question.
No, it's not standard protocol. Also, there's no instead. One thing I didn't mention, we do them almost always without an incision. Right? I'm extracting the tooth without cutting. The only time I'll do a small incision is if I can't get a good purchase on the crown. You want those forceps, and they're designed to fit at around the CEJ, right? I purposely don't use elevators only because I have less skill, less control of the elevator, and I don't want to go down onto the root surface. I don't use cowhorn forceps. I don't want to reach into the furcation area. So I use these forceps that will grip on the tooth. And if the papilla is overgrown and I can't grab that, I might just lift the papilla back. Other than that, there's not even a wound. So the patient, do you give them ice? Sure, you give them ice, will make them feel better. One very important thing post-operatively, and I learned the hard way, is you give the patient gauze to bite on, 2x big one gauze there, 2x2 cotton. And I give them a pack of sterile gauze to take home. And I say, as silly as this sounds, not only are you going to bite on them now, and you're going to take the subway home, you're going to bite on it. And when you get home, you're going to bite on it the rest of the day, other than when you pause to eat or drink. Because when that blood clot is forming, you don't want it to push the tooth back up. So you want to keep that downward pressure for, at least the remainder of the day as best as you can. And then the obvious post-op instructions is, chew on the other side and softer foods, nothing too hard there. But it's almost it's the same form that I give for every surgical patient. And in fact, a lot of times, they'll be sore, but the actual site itself will be less sensitive than when we've raised the flap and the flap is open and the air is drying the bone. It's actually a lot less traumatic on the patient on many, many of these cases.
You don't need to take it out of the occlusion, out of the bite or anything?
So if you think about it, you're cutting off the end of the root and the granulations come out. So usually when I put the tooth in, it's actually a little bit hypo-occluded. Now, I will always check, after the post-op instructions, I'll check number one, mobility. If it's greater than +1, I'll splint. And then I'll check the occlusion. If there is a high spot, I'll adjust it. But there's some train of thought that you want to allow for physiologic mobility. So there's some train of thought, obviously, the more you reduce it, the less potential biting pressure there will be. But there's some train of thought that even if there's a little bit of contact, allowing for physiologic mobility will actually delay or prevent ankylosis.
In terms of how long to spirit one, what would you say? 7-10 days?
Well, if it's a suture, you'll take the suture off within a week.
Yeah.
If the tooth is hypermobile and you're splinting it with a fiberglass, you could keep that on even longer, upwards of a month or so. Fiberglass being technically a semi-rigid splint, as opposed to taking a thick wire or something like that to
Mhm.
splint it.
Amazing, guys. Thank you so much. I've really enjoyed learning about this topic, which really doesn't get the limelight until now. And so it's been an honor to host you both. How can we send our love, emails of thanks or anything like that? How can we reach out to thank you guys for sharing knowledge with us today?
Sure. I've recently made a pledge to try and boost up my Instagram and use it. So feel free to follow me. Just write my first name at whatever. Then yeah,
I just started an Instagram account. I don't even know what my Instagram
Yeah,
I'm very delayed.
Yeah.
I one of the residents started an account for me.
Yeah.
But can I just say, one thing real briefly in closing is that here we go. If you want to look me up.
Okay.
In closing is that the purpose of either when I give the talk or for a podcast like this is to get the word out there that number one, this procedure exists. And number two, it's something that my goal is for everybody who listens to this podcast to at least think about it and to add it as part of the armamentarium, meaning and it's also one thing that we need to mention, economically, it's inexpensive. You pair of forceps and some solution and a little bit of putty. I mean, it's not like I'm buying expensive equipment for this. And of course, we can't do every case. Of course, there are many contraindications with the shapes of the roots and other, teeth that are ankylosed or fragile. But I think it's something that we all just have to include as part of the armamentarium, therefore, as a possible treatment plan for the patients. That's really the goal whenever we give these kind of, discussions.
More importantly, I found his Instagram handle. It's SIK Ratch, basically. Sick Ratch. Is that how you say it?
SIKRATCH.
Yes.
That's my handle?
That's your handle.
Okay, good.
Well, I appreciate that very much. I think this is going to be something that has inspired people. But I always say, if it's your first case coming up or you've identified a suitable case, do your due diligence. Read the papers that you've done. Read the evidence. It's really important to read the protocols that different papers have published and whatnot. That systematic review you mentioned. So if you don't mind, Shiv, can you send us some of these or the links to the PubMed links so I can disseminate information in that manner?
Yeah,
Lovely post cases.
Yes.
If we want,
Yes.
we'll send.
I'll make that
cases.
available as a next step for someone, the person the hungry minds that want to learn more about this technique and who've been inspired. Thank you so much, gents. I really appreciate your time.
No, thank you so much.
Thank you.
Great. There we have it, guys. Thank you so much for listening to Shiv, me, and Dr. Samuel Kratchman. Wow, what a legend and what a cool new thing to have up your sleeve. Like telling your patient that, look, there's one more thing we could still do. The trickiest thing is arranging for that atraumatic extraction. If you can do that, the rest of it is easy. That's a kind of make or break moment. Now, all of this information is being fed into Ask Jazz, our protrusive AI. So if you have a case coming up, of course, we recommend you read the papers and we'll add as many as we can in the show notes and also on Protrusive Guidance. Dr. Kratchman gave permission to send all the resources, which is wonderful. I love guests like him. But also it's available via Ask Jazz. So you can ask Jazz, our AI, any specific part of protocol, any nuances regarding intentional replantation, everything it's learned from this conversation. It will be able to share and reason with you using all the previous episodes we have done and all the resources we feed it. So by June of this year, Ask Jazz it's already awesome, but it's going to be a beast by June because we've got a whole content plan to make it really clever so it can serve you. I want Ask Jazz to make your life easier and also more successful, of course. I want to thank our guests again. Shiv, thank you so much for bringing on Dr. Kratchman. You both were brilliant and we were so lucky to be able to host you both. For those of you on our premium plans, answer the quiz, get the CE, have that certificate and keep racking them up. Keep racking them up. By the end of the year, you don't have to worry about CE credits. You have CE credits coming out your ears. And of course, day by day, you improve 1% and you become the best dentist you can be. And with that, my friends, I'll catch you same time, same place next week. Bye for now.